Great, thank you so much. So as you all came today, one of the things that is definitely important that we're highlighting is the importance of hospital and community partnerships to support transitions. And as Kelly Cronin highlighted in the initial introduction, there's multiple federal and regulatory requirements that require hospitals to do those activities. But we wanted to first start with, what does the peer-reviewed literature state, and what experience is there in the literature that highlights the clinical impact of hospital community partnerships and its impact on quality and performance at the hospital level. And so we want to feature that the AHRQ Patient Safety Network highlighted an innovation that was implemented with a network of 45 hospitals called Prime Healthcare, and the innovation focus was assessing, addressing, and aligning social determinants of health or health-related social needs during discharge. Next slide. And this was also featured in the peer-reviewed literature. So the Joint Commission Journal on Quality and Patient Safety, the link is there for the entire article. If you do download that article, they provide a lot of great detail on what that health system did in terms of implementation, and a lot more detail on the outcomes. Next slide. So a bit of the background, they identified this as network of 45 hospitals, noted the significant health-related social needs that was impacting hospital discharges. And so they started an intervention that aligned with their natural discharge process to also look at screening, assessing, and addressing health-related social needs as part of the discharge process. They started this project in 2018. Next slide. And so before they started the pre-planning, and this is important because as your organizations think about how would we implement, looking at what has been successful. So they're pre-planning, they looked at their claims history, readmission causes, and looked at the different types of diagnoses, procedures done, and clinical outcomes. Next slide. The impact of their intervention on readmissions was substantial. And so this documented a precipitous drop in readmissions over time when they identified health-related social needs prior to discharge, linked persons who had needs to a network of community-based organizations in the community who then mobilized to address those needs as part of an extended continuum of care. And the resulting data that the health system reported is on the screen. And and since they operate amongst 45 health systems in multiple states, they saw that they were able to have replicable outcomes across different geographic regions. Next slide. So amongst their research, they found that these common readmission causes are directly impacted by health-related social needs. So your efforts today to begin partnering with community-based organizations to address these specific needs, as the literature shows, can have a direct impact on cost and quality. And some of those key factors are, among them, health literacy, medication access, resources to care for oneself, and two common factors that we often hear: food and housing insecurity. Next slide. So these recognized implementation practices have shown to be successful. And amongst the one that was featured in this article, these are the implementation practices that Prime Healthcare deployed to get the results that were identified in the previous slide. And that included these key steps: creation of multidisciplinary care teams that include key community partners as part of the care continuum. So they extended the clinical care setting from hospital to community with key essential community partners that formed an organized delivery system of community-based organizations through a hub. They screened for health-related social needs, and then that access to what they called a strong preferred network of community-based organizations was the key intervention that then produced substantial results. And the last key factor was that they established a bidirectional flow of information from community back to healthcare, to make sure that all were working in concert to achieve the single goal improve clinical outcomes for patients that were being discharged from these healthcare settings. Next slide. So now that we gave you examples from the peer-reviewed literature, we want to talk quickly about some of the policies that many of you are aware of, but some of our community-based organizations, other organizations that are not working with health systems may not be aware of the impending federal and regulatory policies that are really requiring some of these actions that's proven to be successful in the peer-reviewed literature. Next slide. So there is a recognition of the impact of health-related social needs on total cost of care. And CMS, in the most recent Inpatient Prospective Payment System rules for FY24, did make a substantial change where they changed the ICDM DRG designation for homelessness, where they changed it from a non-complication or comorbidity to a complication or comorbidity. So whenever a patient is admitted to the hospital and has one of the ICD-10 Z code diagnoses that's listed along with their admitting diagnosis, it's now considered a complication or comorbidity, which then means that the hospital will receive additional reimbursement for that hospital stay based on the MSDRG category for the admission. That is substantial because there is a formal recognition that this particular health-related social needs of homelessness, which includes sheltered homelessness and unsheltered homelessness, adds to the total cost of care of treating a person that's impacted by homelessness. And now through this rule change, there is additional reimbursement that the hospital will receive. So we do anticipate a substantial increase in screening for homelessness as a complication or comorbidity of the admission, which will mean that there are more people identified. And now that this is going to be ideally listed in the problem list as part of the complication of admission, then the expected outcome is there'll be a intervention to resolve this complication of their admission, which leads us right to a strong network of community-based organizations organized as a community care hub in a delivery system to address the social needs of persons admitted to the hospital where a social need impacts their hospital discharge. Next slide. In addition to the IPPS rule change that is in effect today, that now adds homelessness as a factor that increases MSDRG payments because of its a complication of admission, there's also a requirement that hospitals begin screening and documenting health-related social needs as part of the admission. In the FY 2023, it was a voluntary thing for hospitals to complete this. 2024, it is mandatory. So all hospitals do have to begin submitting this data as part of their quality data set that they're submitting. And for FY 24, there are no penalties associated with it, but it is a mandatory report. But there is a rule that requires that penalties will begin in 2025. And so kind of the move is we've identified that addressing the needs is a good thing to do and has a positive impact on clinical outcomes based on the data. We also identified that homelessness as one factor increases the cost. And now there's also a requirement for hospitals to begin capturing and reporting the data around screening for health-related social needs during a hospital admission. Next slide. What is really important as you begin implementing these rules or supporting persons that are overseeing quality at health systems and even your CBO partners, it's important to begin thinking strategically about how we stratify the population, having a priority towards equity, ensuring that we have a seamless data collection process, and we're not just collecting data and submitting data for purpose of collecting data, but having a key eye on analysis. What are the trends around social needs that are impacting the patients coming to our hospitals in our particular market? Are there certain health-related social needs that have a greater impact on quality? So if we look at readmissions, length of stay, are there particular factors that are driving up length of stay or negatively impacting readmission data? And then what things can we as a health system do to organize and partner with a network of community-based organizations to have an impact, and having that as part of a broader quality improvement strategy? Next slide. Additional things that the IPPS rule that requires hospitals to screen and report activities for health-related social needs requires the screening to be in specific categories. The categories are listed, so all the health systems have to begin screening and reporting their activities around food insecurity, housing instability, transportation, utility difficulties, and interpersonal safety, and incorporate that as part of a broader measure on improving quality and clinical outcomes where health-related social needs have a direct impact. Next slide. The requirement, it does require that health systems begin screening, documenting positive screen rates in each of the domains. And we really encourage you to take a population health view where you're looking at trends and those trends on impact and quality, and categorizing the positive screens into those specific categories to see how those trends are impacting the health outcomes. As you begin looking at those trends, then the best practice is to match trends around needs, health-related social needs that impact hospitalization on the clinical outcomes, and aligning that with your community partners where you're matching needs at the health system to resources in the community, and looking strategically on how you can develop a sustainable pathway to address those needs with community partners, providing an extension into the community post-discharge. Next slide. So those are the federal policies. In addition to that, for those who participate and support joint commission requirements at your health systems, they're effective January 1, many of you are aware, Joint Commission added a healthcare disparity requirement, which really aligns well with the CMS IPPS rule that requires hospitals that have Joint Commission accreditation to begin screening and assessing for health-related social needs amongst the population, identifying trends in the disparities and around needs amongst the population, identifying community resources, and developing an action plan. So some of the best practices that we talked around the use of the screening data to partner with community resources to drive clinical improvement is also a requirement with Joint Commission. Next slide. And then this last section before we go into the case study, I know many times I have opportunities to work with health systems, and they talk about the unfunded mandate and provider burnout, and how can we add more into the day without reimbursement. Well, the nice thing is, at the same time, concurrently, CMS, through the physician fee schedule, which began January 1, 2024, the calendar year 2024, there were some specific rule changes that allow a pathway for reimbursement under Medicare Part B for screening for health-related social needs through a new Medicare Part B benefit that's called a social determinants of health risk assessment, community health integration services, which is reimbursement to specifically pay for the labor to address health-related social needs for a Medicare beneficiary that has identified health-related social needs. In addition to that, something called principal illness navigation, which is specifically navigation services to support persons who have a major health condition that's potential to negatively impact their health outcomes. And so these new benefits that began January 1, 2024 can be leveraged to support hospital transitions of care. But because these services are Part B benefits, it does require hospitals that are part of an integrated care delivery system or an accountable care organization and others where there are direct connections with Part B providers that are interested in supporting transitions to now leverage this reimbursement to address those needs. Another key aspect of these new rules is that CMS, the Centers for Medicare and Medicaid Services, specifically outline that Part B providers can and should consider contracting with community-based organizations as part of the delivery system for these services to get the intended outcome, which would be addressing health-related social needs that have a potential negative impact on clinical outcomes. And in the listing of potential CBOs that providers should consider contracting with, they explicitly outline area agencies on aging, centers for independent living, and other community-based organizations that have a history of working with complex populations. So many of the CBOs that are participating in this series were the types of CBOs that were outlined in the CMS policy that Part B providers could begin thinking about in terms of contracting as a third party to be the delivery system for social care interventions to address the health-related social needs of the target population. Next slide. These community health integration services are listed here, specifically outlines that coordination of care transitions are one of these services that are reimbursable today under the Community Health Integration Code Set, as well as the healthcare access and system navigation. Next slide. So the potential implications for hospitals, accountable care organizations, and community-based organizations. The implications are addressing health-related social needs is more than a good idea, but it definitely has been proven through the literature to have a bottom line and financial impact on health systems that embrace these requirements and to develop an intervention model that includes a strong network of community-based organizations as part of the delivery system. It also has a direct impact on total cost of care. And now there are clinical quality measures that are tied to the screening activity. And there's literature that shows that these activities can have a direct impact on other clinical quality measures, including readmissions and mortality data. And in order to do this successfully, there has to be an understanding of the role of community-based organizations during the pre and post-discharge period. Next slide. So as you continue to think about the connection to care transitions, it's important to think about the impact on hospitals. So clearly hospitals, that some of the key drivers for hospitals include length of stay, readmissions, mortality data as well. Impact on accountable care organizations. If we're able to reduce total cost of care, that has a direct impact on outcomes for accountable care organizations, as well as the range of clinical quality measures that ACOs have to report that are over and above the clinical quality measures that hospitals participate in, including hospitals that are participating in value-based payment models. Impact on community-based organizations. So when health systems can partner with a strong network of community-based organizations as part of a delivery system, the new rule changes that allow for Part B billing to address health-related social needs on beneficiaries that are negatively impacted. It provides a sustainable revenue source for a delivery model that instead of doing small pilots or sending a few different cases, you can really look at a population view, identify persons who are negatively impacted by health-related social needs, and then establishing a sustainable delivery model that's able to tap into Medicare reimbursement to fund the delivery system to address the health-related social needs of the target population.